As we have done in the past few weeks, we are trying to mute everybody so there's no background noise, and people are unmuted when they're presenting information or answering questions. So as we go along the different presentations, people can use the chat. So the chat room is at the bottom of the screen. You can go add something to the group or privately to somebody if you want. And we'll try to take the questions at the end of the different discussions. We're also going to ask that if any of you are talking about COVID-19 and MS to colleagues or to students or residents, please acknowledge whatever you will share with people, acknowledging the people who are presenting today and the entities that are presenting it, and acknowledging everybody. We will record the session, so it will be within a day or two on the International Women in MS website, as we have done in the past. It seems that it's very helpful for people who cannot join the call to be able to look at the recording after the fact. So I would like to, I will remind everybody of the goal of the meeting. So the goal is really to have timely discussions and interactive discussions as much as we can to share information about COVID-19 and how it affects patients with MS. We are planning to do that for a few more weeks as long as it's necessary. So today I would like maybe Jan, will unmute you? Are you able to share your screen, or do you want me to share your
I can try to share it.
Okay, so Jan is based at the Karolinska Institute in Sweden.
Let's see if it works.
Yeah, it's starting to share. Yeah, perfect.
Starting to share. I put it on slideshow. Okay, do you see the screen now?
No, not anymore. Now we see it, yes.
Now you see it, okay. So I did show the basics last week. This is the interface of the Swedish MS registry, where you can, where you have a summary of the course of an MS patient that in this case has been followed for over 20 years, and this is the sequence of treatments. So the idea here is that we collect COVID information in the context of already a rich data set and a rich database. And so we have some 17,500 patients, I think, now active patients in the registry, and that is equivalent to 85% of the prevalent MS population. So what we get here is quite population-based. So we have adapted the registry with a COVID module that looks like this. So it focuses on the standard identified through the coordination of MSIF and MS Data Lines. So nothing strange here, but the advantage is that we already have information on demographics, of disease course, of disability, and of treatment, of course. And we've been up some 10 or 12 days now. And so far today, we have 15 patients only so far reported. And these are then reported by clinicians, colleagues, collaborators in the registry, efforts that encompass all of the clinical departments in the country. So we have 15 patients here, 6 of them so far in the need of hospitalization, 3 of these 6 in the need of intensive care. And we have 1 deceased patient altogether. And that was not one of the ones that was in the ICU, by the way. So what was peculiar in the Swedish setting is that we are very active users of rituximab off-label. And out of those 15 that are reported, 11 are rituximab. But as you see here, of the 11,000 patients on any DMT, half are rituximab. So even though this might seem as a great overrepresentation, it's probably not. It might be, but we don't know that for sure yet. But we have 5 of those hospitalized are on rituximab. All of them in the ICU are on rituximab, but the person that died was not on any kind of treatment, actually. So, this is just a first flavor of how we could address the data in the context of the population-based background information. And we hope to fill this in, of course. Our expectation is not to be able to produce any kind of statistically significant finding based on the Swedish population only. So I'm showing this because I want to make the argument that the context of the data collection is important. And this is one of the advantages you can have from this kind of registry. Yeah, I think I'll stop there.
Yeah, very good. Thank you, Jan. Do you happen to know the age of the patients who are in the ICU and the patient who passed away?
I do have all the data. I didn't prepare to present it, but I can say that the patient that died had an EDSS of 8.
Okay.
No. And I know that the first ICU patient we had was a man in his late 50s. But that's all I can say today.
Yeah, which is plenty. So thank you very much. It's nice to see something that is population based, because it really helps put in the perspective of the risk to our patients. So thank you very much. So I will ask maybe Celine, are you ready to share your screen? So Jan, please stop sharing your screen so Celine can grab it. Very good. We're good, yeah.
Okay. Is it working yet? Do you have it on the screen?
Yes, we see it.
Yeah. Okay,
yes.
Great. So I will update you with the French registry of COVID patients with multiple sclerosis and NMO disorders. So the extraction was performed last Sunday. We do it on Sundays usually. So last Sunday we had 142 reports for MS and 4 reports for NMO patients. Today I just checked before the meeting and we had almost 200 patients reported. So the demographics are not very different compared to last week. The mean age was 42 for MS patients, 34 for NMO patients. Disease duration is 12 years, and most of the patients for an MS group is relapsing remitting patients with a median EDSS of 2. So I just looked more precisely about the PCR for COVID-19. And so actually 51% of our patients were tested, and not all of them were positive. 82% of them were positive among the ones who were tested, and the ones who were not had either a positive CT scan or had a very suggestive symptoms that were retained by the clinicians. So this is something that we can discuss, that the sensitivity of the PCR is not 100%, obviously, and even with patients with quite severe disease on the pulmonary scan, despite that, some patients remain negative even after 1 or 2 PCR, apart from having MS. I mean, also in infectious and other units that has been observed. So maybe this is something that that can be discussed about the reports that we are doing. So most of the patients are located in the Parisian region and in Alsace, but there are also many reports that are coming from other regions of France. And these are the data that I provided already last week, but they are updated about the symptoms frequency. So what I can add compared to last week is that patients presenting with anosmia and headache were more likely to be in a group of patients who were not hospitalized, whereas the patients with fever and dyspnea were more likely to be hospitalized. But that's all about the symptoms. And now if we are looking at the clinical condition rating that we used, from not hospitalized with no limitations on activities on the scale 1 up to 7 with death of the patient. So we have, this is the part of the patients in each category with a kind of color scale. So I changed it again from last week just to be to take into account the supposed risk according to several authors who published recently. And so so if we looked at the treatment repartition against the severity, actually we have in the group of patients with the more severe disease, we have a group of patients with no treatment in black, and patients with more active treatment if we think about immunosuppression. But if we are looking at all epidemiological characteristics, including age, EDSS, and comorbidities, plus the treatment, when we do a multivariate analysis, the parameters that are associated with at least hospitalization, so above the scale of 3, are still age and EDSS. And we have also a trend for cardiac comorbidity, but not the treatment so far where we are now in this registry. So, so if you have any question, I'd be happy to answer. And if I may already ask a question or testimony, because we have some question raising from several neurologists. In France, we don't have cladribine except if we use them in clinical trials for phase 4, but it's not, we cannot prescribe it yet, let's say, but we have some question because we don't have so much experience with it. If what do you do if you are about to do the second cycle of treatment? If any has more experience than we do, we would be very happy to have your experience on that. I think it's all for what I had to present today.
Thank you very much. Yeah, so maybe there will be people on the call who have more experience with cladribine. I think in one of the previous calls, people had discussed, postponing treatment with cladribine if patients were due for their second year of treatment. But I think that some of that is really based on concerns and really not on data. So if some people, so I see here, so Oliver Duno has written, I had 2 patients in the last 2 weeks and he continued the second cycle. So I think that at this point, there's really no clear data to base treatment decisions. And that's probably something that we can discuss with our patients when we have to make the decision, and then whether patients are at higher risk of exposure. So in the case of the 2 patients here, Oliver is saying that both are working in home office, which means they have a lesser risk of being exposed to COVID-19, which may also help make treatment decisions. So thank you, Celine, for the presentation of the French data. So we have also, so Mara, you mentioned that you had nothing to update the group about, right? Is that correct?
Yeah, that's correct. We were trying to have more data for the rest of Spain, but for the moment, the data were not available. So we had just a few patients more than what we presented the last week. So we will wait until having more data. Thank you.
Okay, thank you. So a couple of people have chimed in also about the cladribine. The UK ABN guidelines recommend delaying the second course by 6 months. And then some people are suspending cladribine, but you know, months 2, year 1 without delay. So for the months 2 of year 1, Miriam here is saying that she redosed the patient without delay because the patient had active disease. And then Jeanette in Newcastle, Australia says we have delayed second dose, especially in patients with previous treatment. Okay. So, so can I ask, so I think there's, I don't know whether Maria Pia Sormani or Maria Trojano are there, if they had, in case they wanted to say something, just write a little message to us in the chat. Otherwise, I will invite Dr. Zakaria from Egypt to chime in.
Thank you very much, Emmanuelle, for all your help and support. I have one slide to present.
Very good.
So
You can see the screen. Yeah.
Okay. Okay. Now I will just give you a briefing about the situation in Egypt. This is the statistics from the Ministry of Health that was up to yesterday night, where we have the total number of cases of 2,350, and this has raised today to 2,500, with the current death 183. So knowing that Egypt is a country of 104 million people, then these numbers, of course, they are small numbers in relation to the population, which means that we have a prevalence, a current prevalence of about 25 cases per million, and a current death mortality prevalence of about 1.8 per million. We have recently entered, and I would like to thank Dr. Sormani for her help in the COVID-19 MS trial with 2 centers in Egypt. The Ain Shams University Center, which I come from, this represents the largest registry, local registry in Egypt, with more than 3,752 cases. And the second site, which is the Cairo University, and this is the second largest local registry in Egypt, with more than 2,700 files for MS patients. And to ensure the quality of the data, I would just like to tell you that in the last 2 years, Egypt has entered the MS base, and there are 3,600 cases from Egypt in the MS base, making Egypt the number 7 rank in the country enrollment of patients. And by the way, I searched for the MS-based sub-study COVID-19, and talking to the officials, it doesn't seem to exist until now. The problem is that most of the MS patients in Egypt, or most of the patients in Egypt, they consider COVID-19 as a stigma. They don't show up. Of course, the universities are closed, the centers are closed, and the patients are afraid of being quarantined. So most of them tend to isolate themselves in their houses unless they are very severe to the extent that they need to go to the hospitals. And this is why the death percentage is relatively high. It could represent about 7.5, maybe 8% of the cases. This is a relatively high percentage of deaths. Probably this is because they wait until they have to go to the hospital. So in order to overcome this, because of the centers are closed to collect the data, we have been working closely in the past few days with the MS Care, which is the largest patient group society, and has been founded and directed by my dear colleague May Sharawi, who is now the current president of the Multiple Sclerosis International Federation. And they are reaching out to people in order to make them come and declare their symptoms to us and to document their data and not to be afraid of being quarantined. So all this is happening in the past few days. And now we have the foundation to start collecting the cases. Unfortunately, we don't have any documentation to any MS case, and probably because all the cases are 2,500, as I told you, but we hope in the future that we have documents coming out of the patients. And when we have this, I will update you. Thank you very much. Thank you.
Thank you very much for the update about the situation in Egypt. Dr. Lana Peixoto is on the call. So Marco, do you want to update us about the situation in Brazil? So hold on, we will unmute you. You're not unmuted yet, so we can't hear you yet. Fabienne, can you unmute Marco, please?
Yes.
Sorry. Oh, yeah.
Okay, thank you. Thank you, Emmanuelle. I don't have an end slide here, but I would like to say that in Brazil, we have over 25,000 patients with COVID and only 7 patients with MS. And these patients with MS had one with ocrelizumab, 2 with fingolimod, 3 with fumarate, methylfumarate, 1 with glatiramer, 1 was unknown. And we also have 1 patient with NMO spectrum disorders, and this patient was in rituximab. So those are the data I'd like to present. Thank you so much.
Yeah, and so is there an effort nationwide to collect those cases, or these are just...
Yes. No, yes, this is a national data. Yeah, we are trying to put everybody together and to put the data they have individually. So these are national data.
Okay, and these are data that are provided by physicians, not patient-based, right?
No, yeah, by physicians. That's right.
Very good. Well, thank you very much for your update. So I'll ask Mag to actually stop sharing his screen so we can ask the next person to access the screen. Very good. Thank you very much. In the US, can we have an update from Amber and Bruce? I'm not sure who wants to give an update about how data are being entered in the US registry. Amber, I think you're still, we can't hear you. Okay, very good. So I think you're muted from your computer, not from us. Can you talk? So we still don't hear you. Yeah, you're not muted by us, but I think maybe your laptop is is muted. So in case we can't, so Amber, what we can, can you tell us something? Okay, maybe it will work now.
Can you hear me now?
Yes, perfect.
Okay, sorry. So I'll just start. This were just some of the key questions. This is the COVID-MS registry for North America. This is a physician-reported database for collecting COVID cases with patients with MS. We have harmonized our form to the MS Data Alliance and the Italian groups, but tried to make it a little bit more straightforward and easier to complete. So some of our data so far, we have 50 reported cases within the data set right now. 47 are confirmed MS cases. We have a couple MOG and then an NMO case. The majority are female and Caucasian, so pretty typical. And then for our confirmed MS cases, the majority of them are relapsing remitting, and the majority are taking a DMT, so about 90%. A large proportion were laboratory positive, and you can see over here some of the outcomes. We have about 10 hospitalizations, 3 were admitted to the ICU, and we have 1 death reported as of now. So this is our data. We'll have some of the DMT information, specific DMT information coming later. I know our death was not on any disease-modifying therapy and was non-ambulatory. It was pretty disabled in a nursing home.
Okay, well, thank you very much for the update. So I don't know whether, Bruce, you have any additional update to give, or basically we should just use what Amber has updated us with?
No, that's it, Emmanuelle.
Okay.
Yep.
Thank you. So it's nice that the registry was up and running pretty fast, and that people are entering data in real time here. So I have a couple of things I wanted to add, because people have chimed in the chat box, and that's going back to the discussion about cladribine. And it looks like some people are suspending cladribine in year 2 in patients coming from region the most affected. So this is Isavek from Slovenia saying that, but no patients affected by COVID-19 in their MS population. And then there was, I think that was Elizabeth Celius has told us that they have continued treatment with cladribine in some patients with active disease. One case of COVID-19 MS patients on cladribine between the 2 weeks of treatment, and no severe disease. So thank you for all that. So maybe Ellen, Mowry, if you're still around, you can give us an update about the patient base information.
Yeah, hi everybody. It's great to see you all. There are a bunch of centers in the US who are collecting patient-centered data with an eye on going back later to put those data together with the electronic health record, as well as sort of clinician adjudication of outcomes in the end. So at Hopkins, we have one. We're actually studying, or set up to study with colleagues at Hopkins, a number of individuals who are on immune suppressing medications. And it looks like we have a database of about 23,000 people. So we'll be sending out our first batch of questionnaires probably later today or tomorrow. And we were on a call with Jeff Cohen, who I think is speaking in a little bit at Cleveland Clinic, WashU, UCSF, Riley-Wobe, Columbia, and Pittsburgh, all of whom are interested in collecting or making sure we're collecting the same types of data so that we can put those data together ultimately. And as mentioned last week, Kate Fitzgerald and I, who are heading up the Hopkins effort, along with many collaborators, are totally happy to share our REDCap questionnaires, protocol, consent forms, whatever we can do to help facilitate collaborative research and to make things easier. So if anyone is interested, I'll type my email address again in the chat box, and you can send me an email.
Thank you for the update. So do you have already data that have been entered in your registry, or?
Nope, we were IRB approved a few days ago and are just getting our 23,000 people lined up to send out automated messages. So
yeah, very good. Jeff, do you want to give us some updates from the situation at Cleveland Clinic?
All right, am I unmuted now?
Yep.
Good. Yeah, so we also just got started. We got human subjects approval late Friday, sent out 90 test questionnaires on Monday, from which we got, I think, about 32 responses. We interviewed, I think, 7 of those people today just to clarify that they understood the questions. And then our plan is to start sending out 500 per day over the next several days to get to our patient population. We also just got our first access to the Cleveland Clinic Registry, which now includes roughly 20,000 people who have been tested. And in the first data transfer, there were 47 MS patients. So we're in the process of cross-referencing that with our clinical registry. Of those 47, there really was, it was very similar to what other people have reported. Their characteristics mostly reflect our patient population and our prescribing practices. There were 2 patients with serious infection. One died. He was 83, already on oxygen, was not on disease-modifying therapy. The other patient who was hospitalized with COVID-19 actually was hospitalized because his MS symptoms worsened. He also had severe disability and was not on disease-modifying therapy. So probably over the next couple of weeks, our data will rapidly accumulate. So I'll be able to give you a more informative summary. Thanks.
Very good. Thank you very much. So I want to ask if Nikos or Richard, who are leading the UK registry, are on the call or not. We can't see them, but they may be on the call under different names. So if you're there, please, you can message us or to me in the chat box and tell us what's under which name you appear, and we'll unmute you so you can give us an update. Very good. So Maria Trojano, I know you're there. Do you have any updates you want to give us on the Italian front?
Emmanuelle, just the only thing that I can say that we agreed yesterday to merge data from the MSIF 19 database with data already collected in the Italian registries to perform in the next week, 2 weeks, some analysis on risk factors. So I hope that in the next 2 weeks I will able to provide more information, not only on the frequency and descriptive analysis, but also on predictive factors in patients with and without COVID-19 infection.
Thank you for the update. And then Lisbeth, I think you're on the call, right?
It's Nick Rijke. I'm speaking for Lisbeth tonight.
Oh, great. Okay. Very good.
I'll share my screen and you can tell me whether you can see it.
So tell us where you're based.
So I'm based in London in the UK, but working as for MSIF, work obviously is global. And I think Lisbeth has already explained that the Global Data Sharing Initiative is much more about data sharing than it is about data collection. And I'll come back to the sharing bit, but just to say to people that we did provide a mechanism for people to report their data directly if they wanted to. We strongly encouraged them to go through their existing registries and cohorts. But for some people who either can't or were not willing to go to registers, we did provide a mechanism. And so far we've had nearly 800 people enter their data, the vast majority patient reported with a few clinical. And that does include quite a lot of suspected cases and so far 12 confirmed cases. But to come back to this issue of sharing, the real impulse behind what we're doing is to provide a platform for existing registers and cohorts to pool data, to share that in a safe and well-processed manner, partly because, as Jan previously explained, we know that the registers can provide much richer data than entirely new initiatives, but also because we really believe that pooling data will help us to get more powerful answers more quickly. And my web page would indicate that we have no registers of any kind so far, but the good news over the last week is that we do have major registers now lining up to actively share their data. So the next time any one of us shows this web page, we'll still have a little bit from the direct entry that we provided, but far more data, both patient reported and clinician reported, that registries have been willing to share with us. And I would encourage everybody really to contact us if you're interested in pooling and sharing. And that's it.
Thank you for the updates. One thing I would like to ask people who have presented physician-based registries, do you want to share with us whether what's the incentive for physicians to provide data entry, since most people are quite busy? So do you have an incentive such as sharing the results of the whole registry with physicians who enter data? So they feed in information, but they also receive in return some kind of information that can help them make patient decisions. So maybe Fabienne, if you want to unmute the people who have discussed the registries so far, if they can tell us whether there's a way to basically incentivize physicians to be able to participate.
So I can start. We are going to actively be putting some summary results back on the covms.org website for physicians to enter. We're starting out kind of slow and just reporting cases right now, but eventually do plan on summarizing more of the disease-modifying therapies and outcomes on that website.
Very good. And the website would be available to all, or would be available only to people who have provided some data entry?
It's available to everyone. It's a public website.
Okay, very good. Celine, do you want to tell us how you do it, or maybe even Mar, if you want to chime in, and how you share information with people in your countries?
Mm-hmm. So what we have done in France is that we sent a weekly newsletter to the network that we have, the expert MS centers, and so we have but it's not public. It's through email, going through all the centers. So eventually it will be also published, I guess.
But are you able to share with neurologists in general in France, or it's mostly people who work at identified MS clinics?
Yeah, our mailing list is based on the MS expert centers, not the whole neurology community, but it's really spreading through the MS centers, who themselves can also send to their local contacts. So this is, but this is more directed to the MS expert centers.
And Mara, do you want to add something about how you do it in Spain?
So far, for the moment, what we have is more a local registry for our patients, and the Spanish Neurological Society has also created a registry. Oops, sorry. Oh. But for the moment, it's very slowly growing, and we have very little data introduced. So we have to still learn how to share data in our country.
It's true everywhere. So, Kerstin, do you want to add anything about the situation in Germany, whether there's an incentive for physicians to provide information?
So in Germany, there are different possibilities to collect the data. There is from the National MS Society, they have a registry, and they have a COVID-19 questionnaire. I do not know how many patients are in there. And they also put a questionnaire for the patients themselves on their website. That's one initiative. So the registry is physician reported, and also a second questionnaire for the patient, which could be patients not included in the registry. And then there is this LEOS, which I presented before. They have 10 more cases with neuroimmunological diseases since last week. So I will ask them next week or in 2 weeks for an update, because they have to go into their registry. It's quite complicated to get the data. And then there will be a third initiative from the university hospitals to where some of them are not members of the National MS Society registry, to also collect the cases. But so far, Germany has not too many cases, given that it's one of the largest European countries.
Okay, very good. Well, thank you for the update. Anybody else wants to chime in about their registries?
I could mention from the Swedish Horizon. So, of course, your question about how to incentivize data collection is very relevant. And that is, I think, a really key issue that isn't really easy to answer, how you do that in a correct way. For a small country, though, even though we have some 18,000 patients in the registry, we should not expect to have numbers enough to really draw conclusions. And therefore, I'm very hesitant of sharing detailed information at the national level. And that's why we will contribute our data to the MSIF database, rather than posting things that people will just misunderstand. So what I show today will not be what we will be showing on a weekly basis for the public. We will show some data just to encourage colleagues to remain collecting, but we won't show too much.
I see Lauren Krupp, you're there. Lauren, do you want to tell us something about the situation in New York, because you're exposed to a large number of infected patients?
Sure. We're collecting data. We're working through our IRB to be able to dump our, put our red cap data that we're collecting onto the MS Society, National MS Society Registry. We had about 35 patients with MS who are infected. Maybe it's more now. And basically, we're sort of seeing what everyone else has been reporting. The patients who have been hospitalized and ventilated tend to be the ones who are older and on comorbidities. We have a large proportion of patients on anti-CD therapy, I think, but it may be 60 or 70%, but our general MS population, about 50%, 40% are on anti-CD20 therapy. So I'm not sure whether that's a signal or not. I suspect as we get more cases, it won't be. Certainly not in terms of severe disease. With severe disease, the main things that we're seeing is older patients with higher EDSS. In terms of New York City in general, it's a very weird place to be. The city is empty in a way it's never been before. The hospitals are now saying that it's getting a little less overwhelmed. The number of new hospitalizations is actually beginning to go down, even though deaths are staying about the same. New York State had about 750 deaths in the past 24 hours. And it's been about at that level for quite a few days now. But people are thinking that we're at a plateau and it's going to slowly begin to get a little bit better.
Thank you for the update, Lauren. If there's somebody from Denmark who can tell us about their registry, I tried to be in touch with the Danes a few days ago, but I'm not sure they were able to join the call. So then one of the questions we have here in the chat is any data about children? And I think that, Lauren, I let you.
Yeah, we've had several pediatric onset kids. One teenager, 16 years old, has not been confirmed, but she had loss of sense of smell, runny nose. All the members in her family were severely exposed and symptomatic, so I'm pretty sure she had it. She was on rituximab and did well. Basically, we've spoken to her a few times. She was symptomatic for about 10 days. And when we last spoke to her, she never was hospitalized, didn't really have any significant limitation in her activities. Two other pediatric onset patients in their 21 years old and 24 years old are doing well. One was on Gilenya, I think, the other one on Ocrevus, and no serious, not hospitalized, not really seriously impacted in terms of activities.
Yeah, so there are a few cases that have been reported by, so I see here in France, one 17-year-old reporting today, mild symptoms, patient on fingolimod. I think we heard from some colleagues in Boston also that they had a couple of patients under 18 and they were not severely affected, but these are small numbers overall. So on the call, Miriam Mattoscio, you know about some of the data about the UK registry initiative, so you can give us an update. You wrote something in the chat box, but I think it's better if you talk to us in person as opposed to me reading what you wrote. So Fabienne will unmute you. Miriam, are you unmuted?
Can you hear me?
Yes, we can hear you.
Hello. Hi, everybody. Thank you for this initiative. Really appreciate it. So yes, I don't have the details because they've not been released yet, but I'm aware that about 2,800 responses have been recorded on the UK MS registry as of mid of last week. This is both a mix of patient-reported and healthcare professional-reported information. And so also information about whether patients did not have symptoms have been recorded. So it looks like 95% of responses were negative for any symptoms of COVID-19. I have some anecdotal information about patients that have been reported by colleagues in the UK. Personally, we had at my center in Essex 2 patients on Gilenya with confirmed COVID-19 with laboratory analysis, both doing well, not hospitalized. 1 patient on Taxidera required oxygen for 2 days, hospitalized and went home and doing well. And 3 patients on interferon, all managed at home. And 1 patient in between year 1 and year 2 of cladribine, again doing well and managed at home. Obviously, these are very small numbers. I know that other colleagues in the UK at the National Hospital and Royal London Hospital have had similar accounts so far. I'm sure that Richard and Nicholas will be wanting to give more details in a few weeks, I hope.
Thank you. Thank you for the details. So if people have questions, they can write the questions in the text box. So far, I think we've addressed most of the questions that people had. People were wondering how many MS patients had been suspected with COVID-19 overall, and it looks like if we add the numbers from different countries, we're well above 500. One thing that we can't answer yet is basically whether, you know, so we start having some kind of understanding of treatments and the risk of developing the infection and the severity of the infection in those infected. But it will take much longer to have an understanding of the risk of relapse after having the infection. So if anybody wants to add anything here, so I don't see any new questions, so we can unmute some.
Emmanuelle, this is Bruce. I just wanted to say after the last call, I was taking notes and I summed up the number of COVID cases in MS, and it was a little over 600 when you took all of the different report. We had about 10, if I remember last week, different efforts reporting out. So that number's probably gone up some from that time, but just, I think it was like 647 or something when I added it up from what everybody shared last week.
So thank you for that. Aksel, maybe we could unmute you so you can say what you just wrote here.
Did you mention about my question?
Yeah, since you can tell us about the situation in Turkey, so.
Well, so far, to my knowledge, we have about 16 cases with different, under different MS treatments. They are from different cities. Most are doing fine. We have only 1 severe case who was on fingolimod, but had also reactivation of pulmonary tuberculosis, and that's why the patient is in severe condition. My question was, I have a patient on Tysabri who just now recovered for about 2 weeks, and the question is what to do now. Should I go on with her treatment, or should I maybe switch to an interferon for some time, because we have no idea what's happening really. And then now there are some questions that there might be delayed CNS complications in people who had recovered. So I'm a little bit puzzled to do what with this patient of mine who is now recovering and was doing fine on Tysabri for about 3 years and plus.
Yeah, so there is an answer here from Celine in Paris that in patients on natalizumab in the French registry, the next infusion was delayed by 4 weeks maximum. And that's probably, Mara, do you want to tell us also what you have seen in Spain or recommended to do in Spain?
We have had the 3 patients till now in this situation. And what we've done is to delay the maximum that we thought it was safe, the infusion. We have performed the infusion mainly at home to avoid these people coming to our MS center and to avoid infecting others. And so far, the 3 of them are doing very well.
So Aksel, I hope this answers your question. So somebody else here is, so Elizabeth Silius is saying that they are dosing every 4 weeks in order to be able to postpone without high risk if there's an infection. But once patients are infected and they had to stop the infusion, that was your question, when to resume treatment. So I think Mara and Celine have answered that. Any other questions people want to ask before we kind of close this call? So I will just remind the group that the call is being recorded. It will be on our website within a couple of days. Our website is iWiMS.world, so it's International Women in MS. And we're happy to have you tell your colleagues if they want to listen to this call and previous calls, they can go online and find these. Because we know it's hard to have a time that works for everybody, especially since we're on so many different continents. So thank you very much, everybody, for joining. If there's no more questions, I'm sure we will continue to try to hold these calls once a week. So we're trying to ask first people who have data to share about their schedule. So we try to schedule accordingly, and also to we're trying to not have our Australian colleague have to get up in the middle of the night. So that's why we postponed a little bit this one. So thank you everybody for joining, asking questions, presenting your data. I think it makes a world of difference for all of us who have to answer questions from our patients, but also to make treatment decisions on a daily basis. So thank you very much. See some of you next week. Stay well. Bye-bye.